Okay, so this video is for cervical arthrogenic. So arthrogenic, we're thinking passive range of motion, PIVMs, PAVMs, special tests, and bony and soft tissue palpation within this section as well. So after we've done our first part, which is our observation range of motions, which we'll do for everything, we then move on firstly to our passive range of motion. So with passive range of motion, we're looking really for your handhold positions. I haven't got a pillow with me at the moment, but you'd make sure that there's a pillow there on the bed for comfort when you're working with someone with neck pain, and then we can remove the pillow later as opposed to having someone lying there without any pillow. We can also utilise the foot of the bed that doesn't have the hole in it, so there's no hole for the neck to go into as well. Okay, so for these ones, just get yourself a lie on your back on the bed, just with your head at this end. So as Tom comes down there, I'm just going to support the weight of his head. Remember, the head should be pretty heavy, it should feel about 5 kilograms. If it doesn't, it means the patient's tensing, so we need to make sure that they're relaxed first, so we need to have a good support on the neck. Purposely, the bed's a bit lower, so you can drop down into a bit of a squat position. What we're going to do for rotation is put one hand under the chin, forearm against the cheek, and then we're going to just passively rotate the head to the left and back to the centre. So the reason for these is we're clinically reasoning if somebody had pain with active range of motion, but not with passive range of motion, what structures could it be that we're taking offloading and which structures are still kind of being compressed there. Same the other way. Again, using your own body mechanics in that squat position to rotate the neck. Side flexion, you place your other hand on the shoulder just to block the shoulder, and then we're side flexing ear towards shoulder as a passive range of motion. A couple of repetitions is fine there just to kind of see how things go. What we're looking for is, does it reproduce symptoms? Is it stiff one way? Or does the patient report as we're doing these tests? Switching hands there, making sure you've always got support of the head as we go the other way. Cervical flexion then, I'm interlocking my fingers behind the back of the head, passively just taking the neck into flexion. So I'm going down into the squat and out of the squat. And finally for extension, the key thing now is that we keep hold of the head. Now just get the patient just to shuffle down towards me this way, Tom. And keep going. Another one of them. Good, so we've got the edge of the bed there, we can go over now. And again, we can go into that squat position for passive cervical extension up and down. Excellent. So after our passive range of motion is then our PIVMs. These are passive physiological intervertebral movements. Which the reason these are different from the passive range of motions we've just done is because these are maintenance techniques. So with these two, we've got side flexion and rotation. Side flexion, remember the analogy of the stick bending over a knee. So I'm going to use my tips of my fingers of my left hand on the side of the spinous process, on the left side of the neck. My other hand underneath the occiput and around the spinous process at the level above. I'm then just going to side bend the neck, using my fingers as a bit of a fulcrum for the neck to bend over. I can then work my hands up and down the neck to each spinal level, trying to identify which particular cervical vertebrae is restricted or stiff. This can then become a treatment technique which you'll learn in third year. The other position here is rotation, so this time I've got one hand on the spine, on the transverse process of the level above, the other hand on the transverse process of the level below, and with the uppermost hand I'm just lifting on the transverse process, again identifying which level it is that's becoming stiff, as I move my hands up and down the neck. For more detailed videos of these PIVMs, you can have a look on one of the Sol folders where I've put a selection of the different PIVM tests that we've done previously. Okay, so just get you to have a seat on the edge of the bed. As the patient comes up out of sitting, make sure you support the head as they come around to the side of the bed. So there we've done passive range of motion and PIVMs. The next thing would be to do PAVMs, which is our passive accessory intervertebral movements. So these are our central PAs, unilateral PAs, and transverse glides. So I'll just show you how to do those ones as well. So this time you're right to have a line in your front, but with your head just at that side. And then just in the hole of the bed there. Again, in exam conditions, the patient would be dressed down so we can kind of palpate on the actual skin and the spinous process. But the thing you can do here is get your anatomy marks by talking about what the first spinous process you're going to get to. So as we come off the occiput, the first one we'll feel is C2, and then we know we can work down to C7, which is the most prominent one, and C6, which disappears when we go into extension. When you find the spinous process you want to work on, we're going to reinforce thumbs, so one thumb on, other thumb on top, and we're providing a posterior to anterior pressure, downward direction, but with a slight upward inclination towards the eyes because the orientation of the facet joints are about 45 degrees in the cervical spine. Okay, so once we're on the spinous process there, from the head of the bed end, I can apply the downward pressure with a slight upward pressure towards the eyes. And I can work my way down each of those individual spinous process. You can also do this from the side, exactly the same technique, reinforced thumbs, and I can apply the posterior to anterior pressure, downward pressure with an inclination towards the eyes, and I can work through each of those spinous process from C2 to C7. For the unilateral PAs, it's the same procedure, but about a thumb's width away from the spinous process, now on the transverse process. So I'm on the spinous process, come off about a thumb's width, and again I'm doing my PA pressure with an upward inclination to the eyes. What you'll notice about my posture is that my arms are kind of quite locked out. I've protracted my shoulders and I'm using my body mechanics to provide the mobilisation as opposed to me just using my thumbs. Okay, so nice use of body mechanics as I work my way down. Again, we're looking, does it reproduce symptoms? Does one of them feel particularly stiff? Does the patient report pain when we palpate around those areas? Same down the other side as well, to compare left to right. Finally, for the pavement are our transverse glides. So these are on the tip of the spinous process, but from the side, as I try and push the spinous process towards the camera. Okay, so I'm on the spinous process, other one on top, and I'm pushing in towards the camera there at the moment. I come around the other side and I can do the same the other way. As I say, there are individual videos of those techniques with a bit more detail on the SOL page as well. So our final phase then of arthrogenic in this position would be to do our palpation of bony and soft tissues. Now we'd already done that earlier when we were doing our myogenic case study. It's the same for these ones, however the words that you would use when you're describing what you're palpating are slightly different. So what we'd be palpating here would be the facet joints on the articular pillar to the side of the spinous process, mainly because we want to see whether the joint feels tender, as opposed to when we were doing myogenic, it was more concerned with whether the attachment points of the muscle feel tender. You can't distinguish between the two with your thumbs, but it's just the reason that you're doing them for arthrogenic and myogenic is slightly different. Again, our soft tissue palpation would be our traps, the metascapulae, rhomboids, occiput, and any attachment points into the base of the skull as well, there, as we palpate through. Our final two tests, which we do as part of arthrogenic, are the special tests. So we've got the cervical artery dysfunction test, and we've got the Sperling's test. So we'll start with the Sperling's test. So you just have a seat on the side of the bed, just facing the camera. So with the Sperling's test, this is a test for facet joint dysfunction, but also cervical radiculopathy. So if I compress where the nerve root comes from, does it reproduce symptoms down into the arm? So to perform the Sperling's test, patient sat on the edge of the bed, to look up towards the ceiling, and then side bend at the same time, so try and go down to, that's it. Okay, so extension and side flexion, my hand's on Tom's head, and I'm just going to gently then apply a downward pressure. You feel that kind of pinching feeling in here? And same the other way, so extension and side flexion the other side. Is that for the same that side? Okay, so again I'm comparing one side to the other. It's generally quite an uncomfortable test anyway, so it's not a positive sign if it's uncomfortable. It's a positive sign if there's a difference between the two sides there. So that's our Sperling's test. Finally, we've got our cervical artery dysfunction test, and this is the test that we would only perform if there was no subjective red flag signs and symptoms. It's not a confirmatory diagnosis like we would do with an anterior draw test for the knee. This is more of a precaution test if we're about to prescribe some exercises that require the patient to maintain end of range rotations, for some stretches, those kind of things, or if we're going to do lots of manual therapy on the cervical spine as well. So just to show you this final test, just need to have a lie on your back just facing the ceiling. So what we do with this one, we've got incremental phases. The first phase is to take the head into passive end of range rotation, and then to let go. I come away from the head so I can see Tom's eyes, and I'm going to get Tom to count down from 10 to 0 out loud. The reason for that is so I can detect for any slurred speech that starts to develop as he holds this position. At the same time, I'm watching his eyes to see for nystagmus, so flickering of his eyes. Once we finish, I can ask the other red flag signs and symptoms. Does it bring on any dizziness, double vision? Has it brought on any kind of facial numbness or nausea? And And when he eventually gets off at the end of the test, has it brought any unsteadiness, so like ataxia or anything like that? Okay, so just need to count down from 10 to 0, Tom. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Excellent. So no problems there. So what I would then do for the next stage of the test is take Tom round into right rotation. Now the thing to note here is that in right rotation I'm actually testing the left vertebral arteries because I'm stretching those ones. I'd step away and I'd repeat the test again, 10 to 0. I won't do that just for the sake of this tape. If that's fine, what we can then do is go into extension and do the same. So I can put Tom into extension and we'd count down again and I could watch his eyes. And finally, we'd combine the movement. So we'd do extension and rotation to the left. Then 10 to 0, that's fine, and extension and rotation to the right, 10 to 0, and that's fine. No reproduction of symptoms with this test is fine. That then means we can progress on to doing our manual therapies as treatments or giving exercises to work on rotations. If they do detect any symptoms with these, we'd stop the test immediately. We wouldn't proceed through the stages, and this is where we'd be kind of signposting this patient back to a GP or for further investigation or assessment. So that concludes our cervical arthrogenic assessment.